This is the HRSA Learning Collaborative. We are going to be talking today about leveraging Medicaid policies to address social determinants of health. In particular, we're going to be looking at housing and transportation-related issues, health homes programs as well. We're really excited for our presenters from Colorado and California and Nebraska, we've put a number of paper and resources in the Slack channel, so if you're able to jump over there for conversation and resources, either during our time together today or over the week, please enjoy. We'll hear from wonderful presenters today, as well as our faculty, Ellen Lawton from Medical Legal Partnership and Michelle Jester from NAC, and my colleague Janice Akita from CSH. So welcome, everybody. And we are going to start. Next slide, please. With a poll. So looking to the screening processes that you all are doing, we're seeing more and more health centers or begin to screen for social determinants of health. Let us know a couple of things you may be screening for in your health centers. Are you screening for homelessness and housing instability? Are the folks you serve? Are you screening for transportation challenges and accessing health care? Are you screening for other social determinants of health? Are you not screening anything? And part of why you're joining the group today is you're beginning to look for interest in screening measures. So if folks could take the time to fill out that poll, and we will pull those results together for everyone. All right. Last week, we heard some great examples from Michigan and Missouri, and we heard Texas as well, some of our participants about their social determinants of health activities, how the programs and work they're doing started, how they've been growing those programs and sustaining them over time within changing and diverse healthcare landscapes. We heard about expansion states. We heard about non-expansion states, lots of potential there. This week, we're going to hear about programs in California, Colorado. We'll hear both the perspective of a federally qualified health center that has its roots in the ending homelessness movement from Colorado. We'll also hear the perspective of managed care, how they're thinking about social determinants, how they're using Medicaid funding to partner and implement new community resources through the Health Home program. We're going to hear about transportation from a rural area in Northern California. And finally, we're grateful to our Learning Collaborative participants from the Nebraska PCA for stepping up to talk about their work to improve healthcare access and coverage in their state. As always, we want to thank our guest faculty from Colorado Coalition for the Homeless, from Aetna Better Health, from Ampla Health, and our Learning Collaborative partners from the Nebraska Health Center Association of Nebraska. And I want to thank our faculty from last week as well. We'd love to see in the chat if folks, what was their takeaway lessons from last week. I must say the takeaway slide for me last week, and I think for some of the other faculty members, was Julie Tatko's slide from Cherry Health on evolving payment models for social determinants of health. That did a lot to us to clearly articulate the evolution of payment models over time. It reminded me just again and again that social determinants of health is not just a multi-pronged strategy, it's a multi-year process. And we're excited to have this community here that begins to think and work together at all stages of implementing those processes. Would love to hear from anyone else. Folks may or may not be on mute for what we have, anything else about what their takeaway lessons are from last week. I'll put it in the chat. All right. And if we want to expand, all right, and so let's just take a moment. Folks had a couple of minutes for the poll. So you want to close the poll, Jan, and give us the results here? Got a couple of folks not answering. That may be our faculty as well. I'm very happy to see that everybody's screening, everybody who answered screening for some kind of social determinants of health. Some for homelessness and housing, some for transportation, some for others that we didn't cover there, but nobody answered in the none category. And so we're excited and grateful for that one. Next slide, please.
Hi.
Thanks, Janice. And turn it over to you, Janice.
Great. So this is Janice Akita from CSH. Just wanted to jump in here. We gave you some of this information last week. We are getting good live session participation. So most of the organizations who registered are participating live. Others I know are viewing the sessions afterwards. Just a reminder about Slack, about 50% of the organizations have at least one Slack participant. I know that some issues have come up around this being blocked at organizations, although people have worked through them with their IT department. So just a reminder that that's a really great place for resources. We post all the slides and the recordings and homework and everything there. And it's also just a place where you can interact with each other. So for the survey, I just wanted to call out, we'll be putting a survey link up at the end of this presentation. I'll put it up in the Slack room, and I'll send it in the email next week. That's really how we make sure that we can improve future sessions, make them more responsive to your needs, and then also improve the Academy for future participants. So we really value that feedback and hope that you'll fill out the survey. So just once again, a reminder about Slack. And please feel free to use the peer-to-peer channel for just questions or thoughts that you have for your other group members. And then just a reminder about the chat feature. You can use the little blue bubble box at the bottom of the screen to pull the chat up on the side. Once you do that, if you don't see it, that you just see it in a list with participants and then chat, and there's nothing under chat, press that little arrow sign, and then that should pull up the chat window so that you can jump in there. If you have any issues, feel free to email me and let me know.
Hi, and with that, we're going to say thank you to our faculty today. We've got some great folks from Colorado Coalition for the Homeless, Andrew Grimm, who's their Vice President of Integrated Health Services, Matt Malika, who's their Vice President of Housing Assistance, Sarah Roberts, who's their Outreach Behavioral Health Navigator, Deanna Wisks, who's their Director of Housing and Intake Placement. That'll be our first presentation. Secondly, we'll hear from Dr. Rafael Amakuza, who's the Chief Medical Officer of Aetna Better Health for California. He's going to be talking about their health home implementation in a number of communities in California. We also have Anthony Smoot, who's from Ampla Health, who'll be talking about the transportation initiative there. And then finally, our Nebraska Health Center participants, Amy Binky. So today's agenda, we're in that introduction, logistics, session expectations here. We're going on to Colorado Coalition, Aetna Better Health, AMPLA, a participant spotlight. We'll talk about Nebraska, and then next steps and conversation, questions and answers, and also looking forward to the homework questions from the week. Just a reminder, the homework questions are really, nobody's getting graded on these, et cetera. I don't believe we're even tracking those, but it's really to help your health center, to help your team begin to think about. These are some of the questions that we found that are really helpful for health centers as they're either beginning on the social determinant of health work, they're, middle, beginning, end phrases. So please, after the end of today's sessions, we hope the participants will have a better understanding of housing and transportation as platforms for health. We'll help them be able to identify strategies for partnering to grow sustainable state and local housing and transportation interventions. This week, homework questions were all about who are your partners? Do you have the right partners? Are there other partners you need to meet, learn, reach out about in your communities? And then begin to improve and understand overlapping and integrated missions, activities, and investments across health and housing partners. We're finding that the places where these kind of projects, cross-sector partnerships are really taking off is where they've really done the time to align their missions. They've done the time to be able to find who are the right partners for their communities and then build from there. So next slide, please. I also just wanted to highlight there's a lot of work in transportation here. So there were a number of papers that as we were putting together this presentations and this discussion, it was found very helpful. So wanted folks to just to have this as well from our Social Determinant of Health Academy's fellow faculty, health outreach partners, for community catalysts as well. I shared some information with us as well. So we thank them for their assistance here. Next slide. And I think with that, I will turn it over to the good people from Colorado Coalition for the Homeless. Thanks, folks.
Thanks, Marcella. So next slide, please. This is Matt Malika, the Vice President of Housing Assistance at the Colorado Coalition for the Homeless, and I'm going to give an overview of our housing stock, the housing development we have here at the Coalition, and the many different types of vouchers that we serve folks with here. And we're going to sort of then tie that into how we work closely with our health center, the Stout Street Health Center. And one thing to keep in mind here is that the coalition started as an FQHC, and although we have a tremendous housing stock now, we recognize that as a need in our community for the population we were serving, and started housing development and started voucher programs after initially just being a health center. So I think would encourage folks on the phone that or that are listening that are from health centers to really consider how you might add housing programs into the fold, or partner with, obviously, with organizations that are doing that in your community already. But just to say that running housing programs, with the infrastructure, you have, a patient population that's homeless, you have the referral source already at your, in your clinics, that it's not a big step and that it's achievable. And we're going to talk about the coalition's housing and housing development. There's a lot of it, but we didn't start that way. So we're happy to sort of walk it back for you guys at some other point in time. But I'm going to talk a little bit about what we do. So the mission is up. The mission of the coalition is to work. You guys can read that. I think the real key takeaway from our mission is that the creation of lasting solutions for homelessness. So we don't run shelter services here. We do have shelter partners in our community, but we really try to focus on the solutions that that will be lasting in our community and that will really help folks get off the street and stay off the street. So next slide, please. So here's a little bit about our history. 1984, we were established, and the clinic opens in 85. And as you can see, for 3 years, no housing programs, and then we start a transitional housing program for women and children. Then they start on in 1990, we start on the creation of affordable housing. And 1990 to 2000, very busy with 472 units of housing either built or acquired. And we won't have time in this presentation to go into how to acquire or build, but we can also have those discussions offline if anyone wants to reach out and talk. And as you can see, through the early 2000s and after 2010, we start to really look at the integration of our housing and healthcare services at our medical, dental, behavioral health, and then our housing and our programs. So we have a lot of different programs here at the coalition that serve folks in the community. We have a Housing First program, a family support services, and supportive housing programs that tie into the clinic for medical, dental, and sometimes for behavioral health. 2018, our next project, we're about to start the development of a project out in the Fitzsimmons area of those of you familiar with Colorado. It's east, it's in Aurora. This project's going to be 60 units serving veterans, both honorably discharged and with less than honorable discharges. So next slide, please. Oh, and sorry, can you go back one slide? I do want to highlight in 2013, our launch of the Fort Lyon Recovery Program. That's been a huge success here in Colorado. Just want to highlight it's a recovery program in southeast Colorado that serves folks who are having an issue with substance use and are wanting to discontinue their use. So next slide, please. Housing is healthcare. That's our belief. And we believe housing and healthcare are human rights. That slide's pretty self-explanatory. Next slide, please. So some support services that we offer, I highlighted some of these. We have a community resources department, a community resources and outreach department, family support services that also does some outreach and has a community resources wing. We have various case management programs, a vocational program, and we also serve our rural communities here in Colorado by being a pass-through for some what are called ESG dollars, Emergency Solution Grant dollars, that go out to provide rapid rehousing in those communities. Next slide, please. So I'm going to pass it on now to Deanne Witzke, who's the director of our Housing Intake and Placement Department, to talk about how we bridge folks that come into our housing programs and are getting ready for housing for the first time, and how we get them sort of connected to not only housing but also to their clinical services.
Thanks, Matt. This is a lot to go over in such a short time, so I just want to reiterate that we're open to questions and collaboration afterwards. Our information will be available to you all, because this might seem like a lot, but you saw the timeline. It took a long time, but it's working really well. So to go back to housing is healthcare, that's a fundamental belief that we have at the Coalition. And, you know, we talk about social determinants of health, we talk about trauma, and the problem being homelessness, but the transition into housing is also a very traumatic experience for people that can be obviously a pretty critical moment in their lives. And so CCH has dedicated resources to the process between homelessness and housing, and our department is called Housing Intake and Placement, or HIPS. And our team specializes in bridging folks from homelessness to house. We provide outreach and engagement into the community, really meeting folks where they're at right away. As many of you know, housing also is gilded with layers of bureaucracy, and so our team specializes in helping folks acquire their vital documents, the verifications required for the housing applications and voucher subsidies, et cetera. And then additional to kind of the tangible things that we're working on, paperwork, acquiring those things, there's also a very soft layer to it of the emotional experience folks are going through. And so Sierra, who's going to speak next, will talk specifically about the clinical side to that and the link to our health center and long-term care teams. Next slide, please.
Thank you, Deanne. So this is Sierra Roberts. I'm a licensed clinical social worker here in Colorado, and I'm the Outreach Behavioral Health Navigator on the Housing Intake and Placement team. So my role is quite dynamic and very flexible in order to be able to meet the needs of the clients. Deanne touched really well that our clients have experienced quite a trauma history, and we definitely have to consider that as we help them navigate through the intake process. So my role specifically allows for me to meet the client where they are, and sometimes that means outreaching them out in the community, working to increase their motivation or assess their motivation to engage in services. And another big piece is sitting down with the client and completing a comprehensive assessment to just assess, you know, where the client has been and where they are now and where they're hoping to be moving forward. So we go in depth and talk about their social history, their involvement with the legal system, psychiatric history, medical history, talking about, you know, what their goals are once they move towards stability in housing, where they want to be. And through this assessment, I identify any existing or new mental health diagnoses or substance use disorders. And in collaboration with the client, we create a treatment plan based off of any recommendations I might have and the client's goals and where we agree on those two things. During the assessment, I use a tool called the locus to assign a client to a level of care. So that way, once they are housed, they are transferred to one of our many long-term care teams, and they're matched to a team that's specifically built to support the client and the level of need that they have. A lot of the goals that clients identify tend to be just receiving support from a case management team to help them remain in their permanent supportive housing. Simple things such as educational or vocational goals, maintaining a medical health plan of care, getting some counseling or therapy for mental health stuff to decrease symptoms. We do a lot of connecting to our Stout Street Health Center, which consists of various types of care, which is wonderful that I'm able to walk my people just across the street when they readily identify a need and meeting with me in my office, we're able to instantly get them over and get a medical appointment set up, or sometimes even a walk-in appointment, which is great. We have our medical assisted treatment program for people with opioid use disorders. It's really wonderful to be able to provide all of these types of services in-house and have them readily available for our clients, regardless of their ability to pay. Other than that, other than the assessment, I support my team in the many different tasks that they have to accomplish during the intake process, and sometimes I'll sub in and maybe go to court or advocate for somebody who's having difficulty in motel, just kind of being available to do crisis intervention wherever it's needed. This slide kind of briefly talks about the different kinds of things. Most of the services requested by clients we're able to provide in-house, but occasionally we'll have clients who are established elsewhere and just need to be re-referred to a service. And the disability verification that's listed there on the bottom is just another piece in the intake process where I have to just establish that a client suffers from a mental or an emotional impairment that maybe caused homelessness or is contributing to homelessness, and that if they're provided a permanent supportive housing voucher, that it would improve that condition. So overall, it's a wonderful position to be in, and I really love it. Next slide, please.
Yeah, this is Matt again, sorry. There was a slide that didn't make it in. I just wanted to quickly give you some of the statistics around the amount of affordable housing that CCH has. So we didn't, again, we don't have a slide for this, but we'll send it to Marcella or to get up and out with the slide deck. But currently CCH has has developed and owns 19 properties across the Denver metro area. And we serve on any given night 4,123 households in our supportive housing projects. And so we run about 900 to 1,000 scattered site vouchers, and then have several thousand units of supportive housing. So I just wanted to jump in there and make sure folks knew the scale, because we weren't able to sort of establish the scale through the timeline. And now I will pass it off to Andy Grimm, who will talk about health centers.
Thanks, Matt. Good afternoon, everyone. My name is Andy Grimm. I'm the Vice President of Integrated Health Services for the Coalition. In that role, I am our HRSA Project Director, so I am our primary operations executive over our HRSA Health Center program. And I'm sure many of you, after my three colleagues have talked, are wondering how the heck do we structure all of this, and how do we pay for all of this? Because obviously a lot of what we're discussing are not necessarily your traditional reimbursable services. So I wanted to give you a picture of what our health center program looks like and what our integrated healthcare model really means. So the slide that you have up here, that's just a little web there of sort of the programs that we consider to be our primary healthcare services. So we offer obviously all of the HRSA required healthcare services and considerable amounts of additional services as well. So our behavioral health services really look a lot more like a community mental health center might look like in the traditional world. So we're doing a lot of mental health care, substance use disorders, psychiatry, and other things. But we also have a full range of dental. We have an eye clinic, and so as well as an outpatient 340B pharmacy. So much like a lot of you, we're providing the core HRSA required healthcare services. The interesting thing about how our organization is structured is really all of the work that was just described to you rolls up under our HRSA Health Center program. So the work that Sierra was describing as a licensed clinical social worker, that is a UDS visit for us when she sees patients out in the community as part of this process. and that's a behavioral health visit that, depending on the level of service provided, that can rise to the level of a Medicaid billable visit for us. So we really try to utilize our Medicaid PPS reimbursement to be able to provide this full spectrum of services. And so I'm going to talk a little bit about how that all gets structured. So also wanted to say, while we're still on this slide, that enabling services, as HRSA describes them, and specifically case management, are a huge part of our integrated health model across the entire organization, both within sort of the brick and mortar locations of the health center, but also in everything we do in our properties, during street outreach. So there's a huge amount of enabling services and case management that happens as really a foundation for all of those healthcare services that you see there on the slide. So next slide, please. So we right now have 21 locations in our HRSA scope of service. Now, that actually only includes, I've listed here, our main health center. We have 2 other health center locations, 2 shelter-based clinics, a separate dental clinic, and a mobile clinic van. All of our other 21 locations that are in our HRSA scope of service are the properties that we've developed where we have offices where our staff are based, who are providing behavioral health care, providing case management, and all of the other enabling and linking services that we have across our properties. So a lot of those locations, as I said, are our offices, but really uniquely leveraging the HRSA scope of service to get properties that you may work in or develop yourselves into your HRSA scope of service. That makes things so much easier when it comes to being able to bill for those services, to be able to get UDF countable visits from all of those services. And so over the years, as CCH has evolved the health center program, that's been an important part of the HRSA program, is keeping that scope of service updated and really working closely with HRSA and your project officer so that they understand the reason why you're asking to add these sites. Most of our properties have been added outside of any kind of new access point. They're just being added as a location of service. I will put in a bit of a caveat there that because we only receive healthcare for the homeless and public housing primary care grant funding, we don't necessarily have the same service area overlap issues that a traditional health center might have. We overlap the service areas of 6 other health centers in the Denver metro area, but because we're really focused on caring for the homeless population and those who are at risk of homelessness, as well as those people who are living within our own permanent supportive housing and other structures, we're able to work in close partnership with those other FQHCs in our service area to really share the population and make sure that we're all providing the services that we're best suited to provide in the community. That's a huge part of being able to be successful in this type of program and not have it be viewed as you're trying to have competition with other health centers that might overlap those locations where you choose to develop housing. Some of the interesting statistics there, we had 14,154 unique individuals served in 2018 with just over 120,000 client visits. The really interesting point there is 39,000 of those 120,000 visits were UDF captured HRSA enabling services. So that 32% of the visits that we generated in 2018 on our UDS report were enabling service visits. And that includes the services. We also recognized 138 enabling FTE in our UDS report. So of our 384 FTE, 138 of those are doing case management, outreach, and other enabling services. So we also leverage patient navigators and a considerable peer support program, and those are also considered to be our enabling services staff. So I will comment that as you really beef up your enabling services and how those are shown on your UDS report, you're going to get some comments or edits from HRSA when you submit your UDS report to provide some additional explanation to the high number of enabling services that you're providing. Even if you look at that number and the total number of patients, that's an average of 2.75 enabling visits per patient per year. But with the number of patients that we know got the enabling services that we reported on, we only provided UDS captured enabling services to about 3,500 patients. So that's an average of 11 enabling service visits per year for those patients. So you can see the real resource intensity that it takes to be successful at this type of work. And really the only way that we've been able to be successful at this is, as I said, through truly leveraging our Medicaid PPS rate and the Medicaid cost reporting structure. So we capture much of the cost of the behavioral health services and enabling services that we provide in our properties and in the community in our Medicaid cost report. As a result, our Medicaid PPS rate for primary care services is over $320 an encounter. Now, obviously, we've gotten to that high level of PPS reimbursement over many years of development of our programs, working closely with our state Medicaid agency. Obviously, that large PPS rate can raise some red flags and some audits of your cost report to make sure that you're really reporting things accurately. But it's possible to leverage Medicare and Medicaid reimbursement to be able to provide some of these unreimbursable services that are critical to being a provider of permanent supportive housing. And next slide, please. So this is the last slide I'll discuss here before we take some questions. But I did want to highlight one of the primary programs we use to provide healthcare services within our properties and in the community, and that's our Housing First program, which is really based a lot off of an assertive community treatment, or ACT team model, which embeds nurses, psychiatry providers, case managers, other clinicians, and other enabling and support staff on teams that primarily focus on caring for our most vulnerable patients who live within our housing. And so those also include UDS and Medicare and Medicaid capturable services. So we're providing healthcare, billable UDS services in all of our properties, on the street, in all of the locations where we see our patients and our clients.
And that's our director of our Housing First and ACT Services, Carrie Craig, holding the sign that says housing is healthcare. And I know I'm kind of in my time here, so we can advance through the last slide of outcomes and leave that one for folks to look at, and we'll see if there are any questions.
Really, really valuable info, folks. And if you are asking a question and on mute, I know at least I'm not able to hear you. You're going to need to look at your name up on the participant list and click so that your the microphone doesn't have a red line going through it, and then we'll be able to hear your question. All right. Well, because we've got some other good participants there. Jen Yang also tells us that we can dial *6 on your dial pad. That'll also take you off mute. All right. right. Well, with that, I want to thank the great folks from Colorado. Andrew, in particular, I think some real details about the HRSA scope of service and how you leverage and how you ensure that you're not competing with the other health centers, that kind of dialogue, and it's really, really important and I think really helpful to our audience. Next slide.
And I would be happy to answer any questions people have offline, as would all of us here at the Coalition, so feel free to reach out. This is a lot of information. I could have probably spoken for 5 times longer and not covered everything I could have covered. So.
Absolutely, absolutely. I don't know if I don't think I'm the presenter. Jen, I think someone needs to move on to the next slide. I think also included in the slide is contact information for the good people from Colorado Coalition. If that's not the case, be in touch with any of your faculty, myself in particular, Marcella, and we'll be able to help you get there with some more folks. They are incredibly responsive and an amazing group. Okay, so for poll number 2, we want to ask, to put the second poll up, if your agency is screening for social determinants of health, who do you report out that information to? We're going to choose all that apply here. You may use it in your own health center staffing, team meetings, reporting. You may share it with leadership as you're advocating for different programs, et cetera. You may share it with your board. And then you may share it outside your organization, your local health department, your PCA, if you're a health center, not a PCA. I know we've got a lot of good PCAs on this call today. And then you may also share it with your local payers, such as managed care. So please tell us who, when you're screening for SDOH, who do you share that information with? And the poll is open, I believe. And with that, we're just going to leave that open. And then in the interest of time and continued dialogue, I'm going to turn it over to the next slide and Dr. Amakusa to talk about the great work Edna's doing in California. Sir, are you with us?
Yes, I am. Thank you. Can you hear me okay?
Welcome. You sound great. Welcome.
Okay.
Thank you.
Well, thank you. And thanks for inviting me to this very crucial dialogue. And I think the previous discussion was very informative as to the efforts to address the needs of populations. Housing is one of the most challenging ones, and I applaud their work. Very nicely done. So, I'm Dr. Rafael Amisqua. I'm the Chief Medical Officer for Aetna Better Health of California. And can we go to the next slide, please? I'll say a little bit about myself. I'm an internist by training, and I started my career practicing medicine. I've always gravitated towards the most vulnerable, the frail elder. I've always was interested in helping to solve some of the most challenging problems in healthcare. And so from that perspective, I have worked in academic centers. I have worked in hospital medicine. I have worked in federal qualified healthcare centers, very poor community clinics, and very wealthy private fee-for-service Medicare clinics, as well as long-term care. I worked up and down the state of California. And now I'm in Southern California working for Aetna Better Health of California. I've always been interested in what we now call social determinants, but in the past they were not called that. Aetna Better Health of California, well, Aetna, the Medicaid, well, Aetna Better Health is the Medicaid line of business for Aetna. Aetna Medicaid serves 17 states, and in California, we are in San Diego and in Sacramento, California. And those that are familiar with California will know that San Diego is in the southern tip, and Sacramento is in the upper half. We are growing in California. We have other lines of businesses throughout the country, and definitely here in California, including the Medicare and the commercial line of business, which includes vision and dental. But Aetna Better Health of California is the Medicaid version or division. The efforts of Better Health of California are to get as close as possible to the context of our members' lives. We understand the challenges, we understand the difficulties, and Aetna has tried to identify methodologies to be able to reach out and provide a good set of services so that our members are healthy. In that endeavor, we seek to partner with community agencies, definitely with the primary care providers, community-based organizations, and others to ensure that we are working as a team to deliver. And in the old days, if I may say, probably the health insurance was seen as a payer, and often from providers, more a pain in the butt because of the regulatory environment that exists in approving certain payments and such. But I think that, and perhaps thanks to the Affordable Care Act and other work that happened before it, even at CMS, the effort now of the health plans are to help improve people's lives, to influence quality care. As such, and the plan offers then, I oversee care management, complex case management, the utilization management component, pharmacy. We're on track to be certified by the NCQA for quality. We have behavioral health, and we offer a variety of grants and financial assistance to multiple organizations, particularly on the area of the social determinants of health. At this point in time, we have a pretty enhanced effort to help with the opioid epidemic. So we can go to the next slide, please. So to that endeavor, in an effort to better care for our members, Aetna has implemented the health homes. And the health homes is a program that was initiated from the federal government through the Affordable Care Act, really to improve the delivery of services, particularly on the care coordination and care integration amongst all service lines of the plan and of our community partners. As such, the Health Homes program has this component in it, which is comprehensive guidance for effective care management, outlines key steps for effective partnerships, guidance on data sharing among partners, which is very important, provides specific evidence-based practice for interventions, specific focus on social determinants, which I'm very happy about, and outlines specific roles in the care management team. And whereas care management, partnerships, collaboration, etc., are words that are being used throughout the industry, often I find in some instances there isn't enough detail to put an objective, to put a clear outcome, a clear benchmark. And through the health homes, we're happy to say that it has those details so that we can then begin to build an effective intervention. Next slide, please. So the health homes in reality is a whole person philosophy, and these 6 measures are the measures that are part of the program. Care management, and essentially what they mean by care management is engagement in an assessment in developing a care plan. And this care plan has at the center the member. The member guides the care plan. The team helps construct it with this guidance from the member. The next step is care coordination, and care coordination is referred to those services that are put in place to implement that care plan that was built through care management. Third step is care promotion, and that is to help our members achieve lifestyle changes based on healthy behaviors. And through this is the identification of the member's capacity to change, their readiness for activation, and offering guidance as to what those things are that mean healthier behaviors. Transitions of care is very important. This refers to those transfers of care or care settings, changes in care settings, particularly changes from the hospital to the home. Often I tell my staff that when someone goes to the hospital and they are discharged, is good news. That means that for the most part, the problem has been solved. Now you can go home and return to your normal activities, but often we see that it's actually one of the most dangerous steps, and because so many changes have taken place, medications have changed, and depending on the condition, the patient may not have all that's required to return to a normal state in their home. So that transitions of care guidance is very important. This also the fifth step is individual family support services, and that is the assessment of strengths and needs of that particular individual and the family to be able to address those needs. And then referral to community and social services, and particularly on the social determinants of health. Again, this is where we seek partnership with those community agencies that can be a key to enhance a person's wellness. And so this 6 points encompass then the health homes philosophy, and that is what we are implementing. Let me go to the next step, next slide, please. So on the social determinants of health, I've always found that, as I said before, in different people that I speak with, their take on what is social determinants is different. We know, and the research is supporting this, that on health outcomes, social determinants of health account for 80% of those clinical health outcomes, meaning that those social determinants of health are very important. And clinical interventions appear to only account for 20 to 30% of outcomes. So clearly, social determinants of health are extremely important. But having said that, is how do we identify those social determinants? I've always found that the PREPARE toolkit, and PREPARE stands for the protocol for responding to and assessing patient assets, risks, and experiences. And this is a collaboration from a national cohort of community clinics that prepared 17 identifiable social determinants of health with clear outlines and next steps for interventions. Often, this individual social determinants come with the ICD-10 code for proper identification and perhaps reimbursement. We're not sure about that yet. But this PREPARE toolkit, and it's easily searchable on Google. Some of you probably already know about this. So what I have done, or what we have done, is that we have taken those 17 individual social determinants, and we looked and prioritized which one of those we could, at this point in time, intervene on. And we selected these 5 that are listed on the slide, particularly the support services, which can be broken down into either isolation, caregiver need, or caregiver burnout. Housing, of course, cannot overstate its importance, and we break it down by either chronic homelessness, housing inequity, or housing quality, such as, rodents or mold, or just ineffective appliances, faulty electrical equipment, or housing insecurity, meaning those that are behind the rent, who can't afford to pay, and they're at risk of losing housing. Transportation is also one of those areas that make an impact. Financial status and health literacy. So at this point, we have identified those 5 out of the 17 in the PREPARE toolkit for intervention. And it is difficult. It is difficult to outline an intervention, but we're working at it. We're working to, and I'm sure that, as was mentioned earlier, it's something that will evolve. It will iterate into a point that we have clear benchmarks and then capacity to look at the outcomes on behalf of the member. We know for a fact that these are very important factors. We can go to the next slide, please. So the key lessons, personally, in terms of social determinants, it's very important to identify the source of that. Like for me, the PREPARE toolkit was a very important tool that helped me anchor and then support interventions. And these interventions, unfortunately, in today's environment, require resources, and often these resources need to be selected amongst other competitors for those resources. And so it's important to have as clear and as established data of the tools, because then they lend itself to an easier approval to align those resources. Also, number 2, prioritize the interventions. On the 5 that I listed in the previous slide, you would have probably noticed that food insecurity is not there. And food insecurity is extremely important. As a practicing physician, I've seen many patients with congestive heart failure who were repeatedly in and out of the hospital just because of what they were eating. And an investigation led to us finding out that they could only afford, or they were only capable of getting canned food or frozen meals, which are loaded with salt, and that exacerbates congestive heart failure. So food insecurity is very important. However, upon further analysis, we could not feel that we can offer a solid, comprehensive approach. So we put it kind of to study it. So prioritizing the interventions is important. Often we may need to only select 1 or 2, not all, because it's a bit difficult, and we're apt to make a broader impact choosing one versus the other. And then identified existing community resources for partnerships. We have found, and through the work of one of our social workers, who just had like encyclopedic knowledge of the community, and could bring up the names of agencies that were doing work, and then we ended up figuring out a way that we can partner. Some of them are volunteer organizations, some are reliant on resources to pay the rent and pay their employees. So we have built a relationship with them. And I'll tell you an example, not at Aetna, but in my previous health plan, we partnered with this agency that provided education for the caregivers. And they had a 10-week curriculum, anything from first aid, understanding common medications, communication with PCPs, ensuring transportation, just understanding the instructions, the written instructions. So we supported. We paid for those classes. We paid the instructor. We then gave a little token to the participants, the students. And when we left, we were in our 2nd year, and it was just an amazing outcome of that. And then leverage existing resources. As I said, perhaps either within the plan or within the community, there's already an established service. We don't have to build it. We don't have to. And in this case, for example, the Colorado experience. Had I been in Colorado, I would definitely reach out and say, well, how can we work together? How can we begin to identify common goals here? So that's kind of one of the key lessons as well. Next slide, please. So overall, one of my priorities, and I listed it as number 1 priority, is the caregiver as a social determinant. I find that patients, when they are in need, particularly if they have multiple chronic conditions, the caregiver need is extreme. And they may be isolated, which now has been found through some research to be as equally dangerous as coronary artery disease, just because one is isolated and detached from social settings, to actually having somebody who physically is able to help. Or you may have somebody, or the patient may have someone, and in some instances, it could be a family member, a friend, a neighbor, or spouse. But that spouse or that daughter, son may, they have their own responsibilities. So they're being pulled in to give care, often impacting and not have enough care, but impacting the caregiver, and then leading to caregiver burnout. So for me, that is one of the priorities in this list. And kind of list some initiatives, something that exists in the community, such as in-home support services, multi-purpose senior services. In California, I think it's a national program through Medicaid. There's a program of all-inclusive care for the elderly. It's an amazing organization for frail elders that is a one-stop shop. It's transportation, is home care, is physical therapy, is nursing care, provider care, one-stop shop. The T-care is a theory, research coming out of Wisconsin that states that caregivers don't start as caregivers often. We start as family often, and then we transition to a caregiver. And in that transition, we may become burnt out. And when we get burnt out on caregiving because we're not trained, we're primarily family, it adds burden, and it adds also cost in utilization. So it's important to identify it and intervene appropriately. There's also community health workers. Community health workers are a link from health services deep into the community. Community health workers often understand the cadence and the rhythm and the resources in that particular community to better access care and guide the care. And then whole person care, again, this is a federal program in California as well through Medicaid, assessing similarly to whole health homes. But the program is administered either by the county, the city, or an agency directly. And then health homes, and that's what I had described a little bit earlier. We can go to the next slide. So next step resources. There is a wonderful online source. It's called Better Care Playbook, and it's easily searchable. It has lots of articles, lots of best practices. Is very well curated and is constantly being kept up to date. It's a wonderful resource to look and read what other agencies, what other people, other states, other communities are doing. As I've said, also the Prepare Toolkit is also easily searchable. And then Health Leads is an organization that is focusing on social determinants of health. And again, that agency is easily searchable. And once you see it, you will see the amazing amount of resources and work that's being done in communities. It could align with your individual work or plans to build something. Next slide. And I think this is the last slide. Next slide. So with that, thank you, and I welcome any questions or comments.
Thank you, Dr. Makuza. Much appreciated. Questions? All right. Well, I am going to move because I think we are going to lose our transportation expert and Anthony Smoot shortly because he has to go pick up some patients. So, Anthony, are you still with us? And if you're on mute, I believe it's *6.
Yes, I am here.
Oh, great. Thank you so much.
Thank you, everyone, for taking a little bit of time to listen to what I have to say about transportation. I'll be really quick and really brief as I have to go pick up some patients that are due for their appointments. Next slide, please. Why transportation for our organization? Well, it was really simple. To make sure that our patients kept their appointment, what we found out is that 60% of our no-shows were due to lack of transportation. We offer medical and dental and other services, and we wanted to make sure our patients had access to the quality of care that they so richly deserve. And we did a year-long study to find out that our patients weren't keeping their appointments, and we found the reason why is because they didn't have a ride. They were relying on family members and loved ones to get there, taxi services, public transportation. Our clinics are relatively close, within a 5 to 7 mile radius of some of our clinics, and the average travel time for a patient to use public transportation was 4 hours to get to their doctor's appointments, was just unheard of for seniors. So it made it difficult for those guys to want to come to their appointments, especially on cold winter days when it was raining, and it made it even more difficult for them to keep their appointments, so their follow-up appointments. So we wanted to make sure that we had a program in place that would offer the quality of care, and like I said, I went to all of the communities that we actually served. I did a year-long study. I talked to senior organizations, healthcare organizations, public officials, county officials, to discuss what was the issue as far as transportation in the communities that we actually served, and we found that the lack thereof of transportation was the number one problem for our patients. We have 13 medical, 6 dental facilities covering 6 counties. We're the largest nonprofit healthcare organization in this area. We were started in 1965 as a migrant farm working healthcare organization, and over the years we have expanded our programs and services to include a wide range of things, all which if you go to our website you'll be able to see that information on what we actually have to offer. But again, we wanted to make sure our mental health patients had a great service, and transportation was something that we found was in much need. And I know a lot of people who are offering health care facilities in rural areas of their counties or states that they work in. They're probably running into this same issue. Next slide. One of the things we found out is that, well, how do you actually pay for this? When I put this little PowerPoint presentation together, I didn't want it to be too long and drawn out. I wanted to really focus in on some key areas that I thought was important. One of the things that we ran into is when we started our program was when we initially started it with the idea, okay, how do we pay for the program? What do we do? So what we did is I did some research, and, there's Medi-Cal, Medicaid, and then there's all kind of healthcare plans and stuff like that. And what we found, there was an organization called Logisticare. I don't know if any of you guys ever heard of it. They operate in 40 states. They basically work for the state that you actually live in. Their sole purpose is to provide transportation for the patients who have transportation under their medical plans, but they don't own any vehicles, so they subcontract out to private parties, entities, other transportation providers to provide these rides. When we initially started our program, we wanted to make sure that we had a way to build transportation so we can expand our program and make sure that we have the program available not for the short term, for the long term. So we were able to partner up with Logisticare Solutions, and we're able to bill our patients' medical plans. You can't bill for Medicare, does not pay for transportation. Medicaid does not pay for transportation. But other health care plans like Blue Cross, Aetna, other health care plans do pay for transportation, but the patients aren't aware of it. So what we're doing right now, we're actually year 4 of a 5-year project to provide transportation to all the counties we're actually in, and having Logisticare allows us to bill for that so we can expand the program, buy more vehicles, and hire more drivers. Next slide. Again, what we did, and I briefly talked about this earlier, 60% of our patients we found that were canceling their appointments. They weren't able to make it. They were relying on family members and loved ones to get to their appointments. It just was difficult to do. And if you're in a rural community and you don't have public transportation, I can imagine the number of no-shows and cancellations must be well over 75% for their patients who are in these areas that don't have access to transportation through public or family, friends, and loved ones. And what it did is created a real problem with exam rooms as far as emergency rooms. So patients would end up going to emergency rooms. They wouldn't come to our clinic, and then they would be referred back to us anyway. So we found that having the transportation allowed us to do a couple of things: increase our encounters by 90%, which is really good for us. It also allowed us to increase the quality of care for the people we originally wanted to serve. If you go to the next slide, our transportation program, we transport anywhere between 110 to 140 patients a month. When we initially started our transportation program, we started it out for seniors, but we felt the need to expand it for all of our patients, so we opened it up to everyone who needs a ride. There are challenges when you do that, but again, the ultimate goal for us is to improve the quality of care for the patients that we actually serve. Next slide, please. Again, the goal for our transportation is to make sure our patients keep their appointments, improve the quality of care in the community that we serve. If anyone has any questions, if you're ever thinking about starting a transportation program, I'm going to tell you two things that I think that in my experience was vital for us to be able to get this program off and running. You need the support of your executive team. If your executive team does not buy into the program, it will never work. And the second, and I think the most important thing is that you need a great marketing program to market to your patients so they understand that this service is available to them. One of the things that I found out has been doing this, and I've been doing this for 4 years. I started it from the ground when we didn't even have a vehicle, and I just went out and walked the streets and talked to patients and people in healthcare organizations, senior assisted living facilities, to find out what the need was. And we just found that it was just such a need in our community. And, you know, I took it upon myself, along with another young lady who's no longer part of the program, to find a way to make this work. We bought our first van back in 2015, and we've been transporting our patients at no cost to them. And as I stated earlier, you know, we were able to find a way to build their medical plan so we could be able to expand the program, buy more vehicles, and hire more drivers. We're in year 4 of a 5-year program. By the end of this year, I should be able to buy more vehicles, hire more drivers, and expand to all the communities that we actually serve. Again, I'm so sorry for being so short in my presentation, as I have several patients that I need to pick up. I want to thank everyone for giving me a little bit of time today. I've left my contact information in the last email. You can you can email me or call me if you have any questions regarding transportation, how to get it started, what's your first step, what do you need to do. I have more detailed information I can share with you guys, but again, thank you so much for giving me a little bit of your time. You guys have a wonderful day. I'm going to cut my time out and go pick up some patients. Thank you so much.
Thank you so much, Anthony. I know many of the folks on the webinar, on the Learning Collaborative, can absolutely understand with the being pulled in multiple directions. I think that is very much clear, you know, how health centers have to manage every single day. So,
absolutely.
So we appreciate that. And thank you. Your audience understands. So thank you, sir.
Thank you, guys. You guys have a great day.
All right. Take care. And Anthony's contact info is on there. It'll be part of the materials as well. I'm sorry we didn't get a picture of him, so we could add it to our start, but we'll still try for that as well. All right. And so thank you, everyone. I'm starting out of time for questions now, but we are now going to shift to one of our local Learning Collaborative participants. Amy Binke, who's the CEO of the Health Center Association of Nebraska, is going to talk about some of the health center work there and how they're working to expand Medicaid so that folks are able to take advantage of these wonderful opportunities that Anthony and Dr. Amakusa and our team from Colorado have been talking about. Amy, take it away.
All right, thank you very much. Good afternoon, everybody. My name is Amy Binke, and I am with the Nebraska Primary Care Association. I also have with me Jenna Thompson, who is our Director of Training and Technical Assistance. So we can go to the next slide, please. A little bit of background on Nebraska's health centers. We are small in comparison to a lot of other states. We have 7 health centers across our state with about 48 different service locations. Last year, we did top the 100,000 patient mark, so we were very excited about that, and served about 34,000 children and also about 47,000 uninsured patients. Charles Drew Health Center is actually a homeless and public housing grantee, but they are the only homeless and public housing grantee in our state. Next slide, please. You can see from this map about 80% of Nebraskans live in a county that's served by a health center. What we have in our state is a lot of space and not a lot of people. So particularly in our more rural western part of the state, you can see that people travel quite a distance in order to access care at a health center. And where we kind of have that donut in the middle of the state is predominantly frontier counties, which means we have counties with very little population included in them. So when we look at accessing care and some of the issues that come with that, certainly the size of our state and the travel distance that some of our patients have to encounter plays a big role in that. Next slide, please. From a demographic perspective, Nebraska health centers have one of the highest rates of uninsured patients in the country. We are currently third. We've been second or third for several years with a high uninsured rate. You can see about 47% of our patients lack any access to health insurance at all. We serve a predominantly low-income population with about 90% of our patients below 200% of the poverty level, and we serve a majority minority population as well, with nearly 70% of our patients of a racial or ethnic minority. Next slide, please. So, like many other states, for about 6 years, we tried in our legislature to pass Medicaid expansion in one form or another. We were very unsuccessful in trying to do that. One of the things that makes our state unique is we are unicameral, which means we have one legislative body and 49 senators to work with, love it or leave it. So after 6 years of not being successful with the legislative route, a coalition of organizations undertook a ballot initiative. An initiative 427 appeared on our November 2018 ballot. We were one of 3 states to successfully pass the ballot initiative, and actually passed with a 53% yes vote, which is a strong referendum, I guess, on expansion for a very conservative state. And essentially what the ballot did was expand coverage to 138% of poverty, require that the state submit a state plan amendment by April 1st of 2019, and put in a stipulation that the coverage could not be more restrictive for the expansive population than for the existing population. And what we've estimated is that approximately 90,000 Nebraskans will now be eligible for Medicaid with expansion. Next slide, please. So what we thought was going to happen based on conversations was that a state plan amendment would be submitted April 1st of 2019, and coverage would begin January 1st of 2020. What we found out a couple weeks ago when our state held a press conference was that a SPA was actually submitted on April 1st, but along with that, an 1115 waiver concept paper was also submitted, and that coverage would actually be delayed until October 1st, 2020, nearly 2 years after the voters in Nebraska approved the expansion of Medicaid. So that was a little bit of a shock to the system, and so we are kind of recalibrating and shifting gears a little bit as we go into this new potential model of expanded care. Next slide, please. And I won't read through this whole thing, but basically the big changes that will be under our 1115 waiver are taking the currently enrolled adult population and the newly expanded population, excluding pregnant women, persons with disabilities, and the elderly, and moving them all into a new Medicaid program. And within that new program, we're going to see tiers of coverage. Obviously, the medically frail will continue to receive traditional Medicaid benefits, but then people will be split between a basic coverage and a prime coverage model with varying levels of benefits that are available to them. Next slide, please. The other big changes will be the inclusion of wellness requirements and the introduction of community engagement requirements, also known lovingly as work requirements. In order to receive the more expanded level of coverage under prime coverage, individuals will now have to meet both wellness requirements and community engagement requirements. There are also some lockout provisions where if somebody does not meet those requirements, they get put back into a basic coverage, and redetermination has now been switched from 12 months back to every 6 months. Next slide, please. So while we work through, again, this is a concept. Our waiver has not been submitted. We know we have a timeline to work within. And so what we're trying to look at is what our opportunities might be kind of in the midst of this newly formed program. Certainly 90,000 new individuals accessing care. For our health centers, we've kind of estimated that of the existing health center patients, about 12,000 of those patients will now be eligible for Medicaid under the new program. So it presents a significant opportunity for our health centers, but it also brings a new opportunity to look at some partnerships. Nebraska is historically slow in adopting new opportunities and adapting to change, and so as we listen to kind of all of the other wonderful models of addressing social determinants, we seriously take notes and look for opportunities to enact some of those changes. Certainly with our 3 Medicaid managed care organizations, with the introduction of care and case management, those both provide opportunities for our health centers not only to engage in perhaps some payment models around those, but really to use those as a springboard for social determinant activities. We have outreach and enrollment staff already who engage in care management. And then looking at some case management opportunities as well. We do not have any health centers that have adopted Prepare yet, but we do plan on starting a pilot project with one of our health centers on that, hopefully here in the near future. But we also know things like housing programs. We have a managed care company that works to coordinate housing for individuals who need it, but yet they hadn't been working with our one health center that has the public housing and homeless grantee dollars. And so just coordinating efforts between them and looking for those opportunities. Also looking for transportation partnerships down the road, and then working with our Department of Health and Human Services to see how we can partner through community engagement models and making sure that we are assisting individuals as they go through those processes. So much more to come. Again, we're still unpacking what this might mean for our state, and certainly we hope to see more changes to this process. But as we look forward, we will begin to start to see where we can really build upon whatever this new normal will be for us for Medicaid and use that to enhance access to all of the services that impact health for our patients. Next slide. I think that's it for me. I'd be happy to answer any questions that anybody may have.
Folks, I know you are out there. I can see you on the participant list, et cetera. So really hoping folks come in with some questions for Amy or for any of other panelists. We've lost Anthony, but I believe our other panelists are all still with us. Ellen says I have to learn how to call on people, et cetera. And you may be on mute, *6, or click the red microphone next to your name on the WebEx.
So I have a question this is Ellen. Hi, everybody. Really fabulous content, and thanks, Marcella, for leading today. And while people are getting warmed up, I'll throw a question out there. I think one of the things I've heard a lot about today and is having those conversations with payers. And I was looking at the poll data that folks filled out and said, that they were doing all kinds of activities, but nobody was connecting with payers. And so, Amy, I heard you talk about that in particular, but maybe you have some, just hot tips that aren't on a slide for people to think about and walk away with in terms of not formal linkages, but relationship building strategies. That's the question.
This is Amy in Nebraska, and I think really that relationship building is a key piece of that, and it's just sharing of information. We, in our state, again, have 3 Medicaid managed care companies. We try to have them come to the PCA board meeting at least once or twice a year just to have a conversation with our health center CEOs. It's pretty rare that you can get them all in the room at the same time, and it's nice to be able to just have that conversation outside of the other conversations we might have when there are billing concerns or pre-authorization issues that come up, and we're kind of on them to get problems fixed. It's nice to be able to have a dedicated time where they can provide an update to our health center CEOs, and then our health centers can talk to them about some of their projects that they're working on too. And they've been able to form some partnerships even around things like community baby showers that we've been able to connect people with and put opportunities in front of them to be able to do that just because we work on building that relationship.
Great. Colorado?
I like that. I like that example, Amy, because you talk about how when you have an agenda around expanding Medicaid, because that's going to be helpful to you, both to your patient population and to your bottom line. The health plans have an agenda of expanding Medicaid. It increases the number of members they have, increases their reach, et cetera. You have those aligned agendas, and, you can really jointly put some things forward there. So that's exciting. And Ellen, I interrupted you with your
I was wondering if Colorado had, I'm just always curious how you, it's one thing to have leadership have payer conversations. It's another thing knowing that in the audience today we have folks that are closer to the front lines, and how can we help to model, what those conversations might be.
Yeah, I think this is Andy from the Coalition in Colorado. We're in constant communication, not only with our managed care organizations that have the various Medicaid regional contracts here, but also with the Department of Healthcare Policy and Financing, which is the Colorado State Medicaid agency. We have we've been doing relationship building with the state around the work that we do since the coalition really started to provide healthcare services. And I think a good example of how we really worked in the past to get some changes made was getting our state agency to consider the street to be a person's home for the purpose of billing and for address verification and all of those things that are generally assume that a patient has a fixed address and a location to receive care. So that's critical for the success of our street outreach, as well as for our ability to see patients in multiple different settings and situations. So that's just one example of how critical it is to really work with your state agency and the managed care organizations to let them know what you're doing and what flexibility you need to be able to provide services to these vulnerable populations.
Oh, sorry guys, I was on mute. That's really helpful, Andy. Just thinking it through, because one of the things I'm always remembering is how complex this is, how many different payers and people and different stakeholders you've got to bring to the table.
Yeah, and I mean, a good example, we even know nationwide among healthcare for the homeless organizations that states have very different views on things like street medicine and providing care in people's permanent supportive housing residences. So that's not consistent from state to state either. So it's really important to have those conversations with your state agencies.
Yeah. Amy, we've got a number of rural states on the phone. Anything you feel like is particular arguments that really, go further when you're making those cases with the state when you're in a state, as you said, with more space than people?
Yeah, and I think that is, whether it's, dealing with a state agency or even on the national level, sometimes putting that in context is really important, because even when we deal with our HRSA folks at the national level, if we say it's an 8-hour drive to our furthest west health center from our office in Omaha, Nebraska, that resonates for somebody who maybe spends most of their time on the East Coast and they can't imagine driving 8 hours to get to anything. But that's just kind of the normal for us. But certainly Certainly when we talk about access to health care, and we talk about the fact that people drive 120 miles one way to access a health center because they do not have the ability to get care anywhere else because they lack health insurance or they maybe lack a provider who accepts Medicaid in their community. That goes a long way when we're talking about funding for the health centers and maintaining state appropriations for the health centers in times of budget crises, but also when we talk about the importance of transportation. You know, we have private foundation dollars that have secured vans for our rural health centers to help bring people to the health center to address some of the very issues that we've discussed here today. And so the ruralness of the center, I think, can add one more layer of complexity when we talk about reaching underserved patients.
Yeah, that's really important here. All right. Can we go to the next slide here? Next slide. All right. In the conversations that we had, both the conversations we've heard from the outline, from the presenters, and even in the conversations just building up to these, there's a couple of points that I just wanted to make that I think is really helpful for folks who are just starting out. I think that was our initial comment from Leah at the start of this. At the start of the session, was there's a process we've heard about social determinants of health, and Anthony really highlighted this as well. So an issue gets identified. It gets identified by the health center staff, or it may be the patients, or it may be clinicians or leadership. Somewhere says, you know, this is an issue. Transportation, Amy, your example, in rural states, the homeless challenge in Denver, et cetera, and in many other communities, et cetera. The issue gets identified. Data gets collected. You want to understand how big, how broad, prevalence, what's the need, and then what's the impact on health outcomes and on health center operations. That data then gets shared with leaders and funders. We commonly will see a pilot project, and part of that pilot project is not just doing the good work you do every day, but part of it is also developing the data that you need, not just to document prevalence, but also to really the financial information you need to build a return on investment case. So those materials get developed both for your local health system leaders, but also your state partners, your PCAs, et cetera, and in particular the state Medicaid office, as you can, and your health plans as well, as you can make that argument of, you know, this is the change in cost. This is what we think the impact will be. This is why we think the impact will be. You can go from there. So that's the process that we're hearing evolving over time, and just wanted to share that with you and see if that helps you think about where are you on the road to building and growing your social determinants of health initiatives. And as we talked about before, waivers and state plan amendments, changes in your state Medicaid plan are a big possibility for how to do that, and we will learn more about that next week. So next slide, and I believe I'm turning it over to Michelle. Michelle, you might be on mute.
Hello?
There you are.
Okay, great. Thank you.
Yeah, wow.
So Nebraska's presentation was a great segue to what we'll be covering next week. So Nebraska, thank you so much for being willing to share and for all your great work. So next week, we're going to be talking about how you guys as health centers and PCAs and networks can really engage with your Medicaid agency and really inform the policies that might be coming down the pipeline related to social determinants and the practice as well. So we have a great roster of speakers. We have one of my colleagues, Bethany Hamilton, who's going to kind of give you a lay of the land of Medicaid waivers. I know we heard a little bit about that in our first webinar, but she's going to give you a lay of the land in terms of like all the different steps that you could take to inform the Medicaid waiver process. Then we're going to hear from a PCA. We have Kristen Dubé from the North Carolina PCA, and they've done amazing work engaging their Medicaid agency in the formation of a statewide social determinants of health tool that pulled a lot from Prepare, thanks to North Carolina's advocacy, and also statewide social determinants work with a statewide community resource platform and other policies and reimbursements and payments related to social determinants. So they'll talk about their tips and strategies for engaging Medicaid and informing that. And then we'll also have a health center perspective. So we'll also have Melissa Mather from a family health center in Louisville, Kentucky. And she's going to talk about all the amazing things that they have done to engage their Medicaid agency so that expansion could go through, but that they also push back on work requirements. So she has really amazing stories and tips and strategies about all the different ways they engage the media, they engage their staff and their community to really educate everyone and to really get the word out about what are the benefits of this and then what are some downsides. So great roster coming up next week. We hope you join us. And if you go to the next slide, some homework for you guys for next week is that we just want you to think about how have you or your organization engaged your own Medicaid agencies or other key policymakers or payers in your state. So if you have, what strategies have you used? What seemed to work well in terms of messaging, data, resources? What didn't work so well? And then where are you struggling? Like where would you really like more assistance, and how can we and our wonderful panel of presenters help you in that? So we hope that you submit them to either Janice, and her email's on the slide, or submitting them to Slack. And I think I'll turn it back to Marcella.
All right, thank you. And last slide, I think we want to say just a big thank you again to our folks from Denver, our folks from San Diego, our folks from Northern California, and our folks from Nebraska, saying thank you for all this great information and getting your name and your information out there to all of our audience here. And of course, thank you to HRSA for allowing us to pull this all together. And with that, at 4:30, I will say thanks, everybody. Have a great week, and we will see you next Thursday. Thanks all.